So thank you very much. I've decided that I don't really care about the Affordable Care Act, and let's talk about payday loans. Because I hear that's a real good topic that could have been exciting. So 310 of these, or this is 311th, and it is one of these kind of things that I don't often refer to it as Obamacare, although in the last election, President Obama took care of that. He owns the term, apparently. He put out coffee cups that said Obama cares. So it does not really, I don't think what we call it is as important as we understand what's in it. And in the next 45 minutes, I will try to go over what's in it. I would like to, in lieu of a Beatles joke about help somebody, I think that's the theme of it, I thought we'd go with something like this. Yesterday, the New York Times reported that fewer and fewer Americans are going into the middle class. It is easier to get into the middle class in Canada than it is in America. Now, if there are two grossly misunderstood terms in the American political landscape, it is the middle class, because everyone thinks they're in the middle class, and it's health care. But let's talk about how they relate to each other for a second. If you are not in the middle class, you are more likely to live sicker and die younger. If you are not in the middle class, you are less likely to have insurance, you are more likely to have medical debt, and you are least likely or less likely to understand health care and health insurance. Which is to say that when we think of this economic kind of measure of the middle class, we're really talking about a multivariate understanding of what it means to be in a middle class in America. Because if you are not, your health is in peril as well as your financial health. That said, the Missouri Foundation for Health, why would you trust me? Why would you believe anything I have to say? I start all of these presentations by saying the Missouri Foundation for Health is a non-for-profit. We are nonpartisan. We do not engage in political dialogue. We engage in education. If you want to know anything about the fine line between lobbying and advocacy, you'll know that that's a pretty fine line. So I pledge to you today to tell you the good, the bad, and the unintended of this law. And it's more interesting from my perspective, and I don't know if it's because I've read the law 4 times, the unintended impact of it. Because the good and the bad are here, but what happens as a result of it is equally as interesting. So, if you have any questions as we go along, please raise your hand, shout them out, let's get on with them, because I think it's more interesting for you to have your questions answered than it is for me to knock out a number of slides. This is implementing the Affordable Care Act. And it is implementing the Affordable Care Act. So let's say that the most important thing we need to think about is how do we, just move that one. How do we answer the big question? Do Americans have a right to health care? Do Americans have a right to health care? Does America, as a system that spends more on health care than any other nation in the world, but has middle or poor outcomes, do businesses have a right to demand more from the healthcare system? And as individuals who often enter the healthcare system without knowledge, without power, how is it that we get to being better informed and more in charge of our healthcare? Now, enter the Affordable Care Act. The Affordable Care Act was passed in 2010. It was passed as a result of nearly 60 million Americans not having insurance. Now, if you think about the uninsured, and many people in this room, to be truthful, myself included, didn't give much thought to the uninsured. Put the uninsured aside, and that's tough. But let's think about the fastest growing sector of insurance recipients in America, the underinsured. Those people who have insurance plans that put them into financial peril because their plans have high deductibles. Not so long ago, I have a friend who got a job, and he has a new child, and he was told that his health care plan has a $13,000 deductible. A $13,000 deductible. The interesting thing is he works at a hospital. He works for a medical group. And you say, well, how do you get to a $13,000 deductible? Well, it's pretty simple. When you run a business and you decide to offer insurance to your employees, you say, how can I afford this? And one of the ways that you go about affording this is having a high deductible with lots of copays. Now, we see the uninsured, we're seeing the uninsured, and this is what the Affordable Care Act came into being. The Affordable Care Act aimed at getting more people insured, getting more people able to afford their insurance, and helping those individuals who could not afford insurance either to purchase it on their own or to get it through the state in an expanded Medicaid program. So think about this. Think about this visually. There are three major pillars. First major pillar is the individual mandate. Every American has to purchase insurance. The second pillar is a marketplace or a place to purchase insurance. And the third pillar is assistance to help individuals purchase insurance through subsidies and or a government program. Is this, am I going to get, so.
Yeah, I sent the clip to go get new batteries.
So, I'll just go. So, when you think about these three pillars, the aim is getting more people insurance. Now, let's think about the first thing. The first thing is, how do insurance companies sell insurance? Insurance companies sell insurance. Here's my slide. It should be by date. Insurance companies sell insurance by figuring out who is going to use insurance. I'm going to tell you that insurance companies know more about your health than your doctor does. And why do they know that? Well, they put together actuarial models that predict how often you are going to use insurance, what they will be paying for, and they charge you according to those numbers. Now, right now, the number one way in which an insurance company keeps its costs down is not selling insurance to people who will use it and charging more to people they think will. These are pre-existing conditions. Do you know what the number one pre-existing condition in America is? Number one pre-existing condition in America. If you sort it by date, it should be one more. There we go. Is that it? No, that's not it. Being a female, thank you. So the number one pre-existing condition, although I do think that it's running neck and neck with diabetes and obesity, although the Institute of Medicine hasn't quite made diabetes or obesity a pre-existing condition, but the point is that women have been charged more. Starting January 1st of this year, women are not going to be charged more. That's the good news. The bad news is men will be charged what women were charged before. We're all going to be on the same playing field. But this is all part of changes to how insurance is sold. Insurance can no longer exempt you on the basis of a pre-existing condition. It can no longer exempt you on the basis of where you live and your age per se. Now, it can charge you more for your age, but we can talk about that in a second. The idea is that everyone in America will have an offer of insurance. Everyone in America will have an offer of insurance. So, if you have an offer of insurance, and you can just make that. There we go. So you can.
Now the thing will be back.
Good. So here we go. 90,000. If I were to say, what is 90,000? 90,000 to you would be how many people would have lived in America had they lived in France, Canada, France, England, or Japan. Now, I did present this not so long ago, and a Canadian came up afterwards, and she kicked my rear. And she said, you know, in Canada, we have universal health care, so you should include Canada in that number. So there you go. 90,000 people in America died who would have lived if they had had insurance or lived in a country that had universal health care. $1 out of $3. This should stagger everyone here. Everyone should be up in arms about this. 33% of all Medicare dollars are spent on the treatment and control of type 2 diabetes in Medicare program. Type 2 diabetes is largely an avoidable condition. 33% of the Medicare budget is spent on something that is wholly avoidable. And third, $2.5 trillion. This is $2.5 trillion a year are spent in our healthcare system, and you will see that $765 billion of those dollars are spent on unnecessary or wasteful, i.e. wholly avoidable charges, costs, overhead, administration, etc. So I say this as a way of saying, listen, our healthcare system is broken. Now, when you think about our healthcare system, let's get to why most Americans are uninsured. You will see that most Americans who are uninsured are without a job. If you do not have a job in America, you will not have health insurance, which there was a new study by Health Affairs that came out last week that looked at people who would not get insurance through the expansion of the Medicaid program. And it said it is expected that people who are on the Medicaid program currently or who would have gotten onto the Medicaid program are employed, and they are employed in places that do not offer insurance. And it's likely that they will remain uninsured even after this law is fully implemented. Which is to say, this law is going a far way towards improving the number of people who have insurance, but not everyone is going to be insured, and we have problems to deal with. Now, let's get to what I was talking about before. The Affordable Care Act expands coverage. It changes the way insurance is sold. It puts a premium on prevention and wellness. It increases quality over quantity, and there are new models of care. The bottom three I will not touch at all. If you want to call me and talk about them and be bored to tears, please feel free. I will give you my number at the end of this presentation. The sum total to take away from this is that this law is just not about getting more people insurance. It's not about requiring every American to have insurance. It is also about changing the way health care is delivered in this country. Now, I was asking you to imagine this. This is what I was speaking, the kind of three pillars of the law: the individual mandate, Medicaid expansion, and the exchanges. Technically in the law, they're called exchanges. Focus groups looked at them and said, guess what, Americans don't like exchanges. It's too complicated. So the federal government said, well, they're no longer exchanges, they're now marketplaces. I stick true to the law, but a marketplace and an exchange is the same thing. It is where you, as an individual, or you as a small business owner, can go to purchase insurance either for yourself or for your business. Any individual can go to the marketplace and purchase insurance. Only businesses with 50 or fewer employees immediately, up to 100 in the next couple years, and after that, possibly all businesses will be able to go to a special small business exchange to purchase insurance. Now, here are the new rules I was getting at. No annual lifetime limits. If you get cancer, you never have to worry about running up against a lifetime limit. Oftentimes we see cancer patients run up against a $250 or a $300 lifetime limit, after which no doctor needs to have to treat you. That is no longer the case. To be truthful, no dropping coverage if you get sick. This is more something we saw in California, where you got sick with a high-cost condition such as cancer, HIV/AIDS, and the insurance company went back and looked at your application and said, uh-oh, you lied. You had asthma. You had a pre-existing condition. They denied your whole insurance claim. They denied your insurance package, and you were on your own, most likely to go into medical debt. There are no pre-existing condition exclusions. I touched on that. There are rating rules. That is, currently there are very few rating rules. How much you get charged is based on actuarial modeling. But this law says, guess what? There are 3 to 4 rating rules, and you can only be charged on those rating rules or those banding qualifiers. Guaranteed issue, every American will have an offer of insurance. An enterprising young student in the back should shoot up their hand and say, but can we afford it? Now, whether we can afford the insurance package or not continues to be a question, will continue to be a question, and it is not answered. But for some sectors of the population, the marketplaces have made insurance far more affordable, and for other people, although it's a smaller group, it has become more expensive. I think we can safely say from the numbers we know that the marketplaces had made insurance more affordable for more Americans than any other time since the insurance system really was set up. Young adults can stay on their parents' insurance, 2,500-page law, and this is the single most popular component of the law. It is also, some public opinion polls suggest, the single most misunderstood component of the law. Some people think this means that their children can stay on their insurance for free. This is not the case. If you know how family plans work, insurance companies can charge you for what that extra person would be. Some employers across the United States have taken more of that cost, taken on part of that, but it is wholly legal for an employer to pass on all of those costs. Finally, I talked about affordability. What did I mean by that? The insurance companies must spend 80 to 85% of all the money they take in on actual care. This is the first time that this industry has ever been regulated to how much they have to spend on care. There is a small subsection of this part of the law that doesn't get a lot of attention, but last year was the first year that insurance companies had to report on how they spent their money. Up until now, insurance companies never had to report that. This is related in some capacity to the fact that there are only 2 industries in the United States that allow for collusion. Does anyone know what the 2 industries are? Collusion can take place in the insurance industry, and it can take place in pro baseball. Companies can collude on prices and trading and insider information. Insurance companies are now being held to a different standard. Collusion can still take place. I would argue that the marketplace allows for more collusion than ever, because now you don't have to call up another insurance company. You just need to go on the website and know what they're going to charge. But they have to report to the federal government and to the state government how much they take in, how much they've taken in, and how they've spent the money. This is all predicated on the idea that if they spend more on care, they will spend less on administration. You may say to yourself, what happens if they don't spend the 80 to 85%? They must return those funds in the form of a rebate check. Last year in Missouri, there were $62 million returned in rebate checks to policyholders who got a rebate because their insurance company did not meet this. Now, you may say to yourself, why didn't I get a check? Well, here's the interesting thing, and it speaks to the schizophrenia of what's going on here. So Health and Human Services at first said that the check goes back to the employer, and that the employer does not have to give it to the individual policy holder. Then HHS said, well, some of that should go back on a percentage of how much the individual paid, which then employers and insurers said, are you kidding us? You have someone who's paying 10% of their premium, now I have to figure out how much of this 10% I got back. So HHS said, guess what? You can make a choice. You can keep that check, but we're asking you to keep that check and use it to offset the costs of next year's premiums. So lots of employers, some did return rebate checks, but some held that to offset the cost. So when you hear people saying that their insurance prices went down this year, some of that has to do with this, what's called the medical loss ratio, and the application of that credit to their next year's premiums. The individual mandate, it's important to note that most people misunderstand this, and most news outlets have miscast this. Most people understand or think that it's $95, $325, and $695, which strikes me as very odd amounts anyway. Why didn't they just make it $100, $350, or $300? But they put some sort of calculus to this. The fact is that is based on some understanding of a tax threshold. For people who are above the tax-paying threshold, it is not $95. It is actually 1% of your family income. And the next year it's 2%, and the next year it's 2.5%. So if you elect not to purchase insurance, you could be paying a significant fine for not doing so. Stop. But the fact is that if you are earning above, thank you, the threshold for paying taxes, most likely you have a job. And if you have a job in America, 63% of all individuals who have insurance get it through their job. So the fact is that you could be playing roulette if you earn more, but if you earn more likely you're already insured. So the first thing is understanding that it isn't just 1%, it just isn't 95, 325, and 695, it's actually 1%, 2%, and 2.5%. The second question is what happens if you don't earn enough money to pay the $95 tax? Well, I answer this in a number of ways. I know this is being recorded, so I'll be careful. The IRS is enforcing this, what is the likelihood of the IRS investigating every single person who does not pay the fine? Statistically, it's probably pretty small. If you're listening, IRS, I don't know the real number, but I would still pay the fine if you're being fined. The second thing is if you don't earn enough to pay taxes, you're not going to be fined. This does not come off as they do not garnish your wages, they don't go after your house. This is all based on your income tax and your income tax return. So lots of people who deal with the financial sector say, how do we go about paying this? What we are responsible for? What will my clients be responsible for? It has all to do whether you pay taxes or not, and it all is based on your income. It will not go against your house or your wages. It is important to know not every American will purchase insurance. Individuals of certain there are some religious exemptions and financial hardship exemptions. Mostly we're talking about financial hardship exemptions. What are we talking about? In a couple slides, I will mention the Medicaid expansion program, but if you do not qualify for Medicaid expansion, which is to say your income is lower than 100% of poverty, if you do not qualify for those subsidies, you are exempt from purchasing insurance. So put it this again, if you are too poor to get help in purchasing insurance, you are exempt from purchasing insurance. So we are taking the people who need the most help, and we're giving them no subsidy to purchase insurance, which makes them exempt from the individual mandate. There is some confusion as to whether you need to fill out a form stating that you are too poor to be able to get help. It's just safe that if you have clients or you yourself have family members, it is safer for them to contact go to healthcare.gov or covermissouri.org. We have a website that will allow you to find a counselor that will be able to assist you on what you need to do relative to the application of and the exemptions hitherto the individual mandate. So, that said, marketplace. Why is the marketplace important? Here's a slide that we've been trying to redesign for 2 years, and somehow we just never get around to it. So you see if you're green and you're sick by yourself, you pay the most for insurance. But if you're part of a family, there are more healthy people to offset the cost of sick people. If you amplify that up to a large employer, you will see that there are a lot more healthy people to offset the cost of sicker people. So when I say this from a place of knowledge. The Missouri Foundation for Health, 2 years ago, we saw our premiums go up by 37%. And when asked why, we were told, well, that's just the cost of doing business. And we said, actually, come on, there's got to be more to that. And they said, well, you've had adverse usage. And we said, what does that mean? And they said, well, you had one shoulder surgery, you had one breast cancer, you had a number of stress tests and possible health scares. That is, the people on the staff use too much health insurance. We're afraid they're going to do it again, so we are going to charge you 37% more. Now, the Missouri Foundation for Health only has 47 workers. If we had 470 workers, those adverse usage numbers would not be the same because there would be more healthy people to offset the cost of the sick people. That is what a marketplace is. Everyone who goes to the marketplace and purchases an insurance is essentially going into a large group market, and it allows for better negotiation of prices and lower prices. Here is the individual market. Here is the marketplace just by way of numbers. It's like a farmer's market. You can go to, individuals and small businesses can go, guaranteed issue, rating rules only on age, tobacco, there is one on geographic location, but it is not being applied the way you think it is. If you go on the marketplace, you will see that there are different prices based on geographic variation. I will note to you here, I've been saying this everywhere I go, you do not see obesity as part of this. If you smoke, you will pay more. If you are older, you will pay more. If you are obese, currently you will not pay more. Congress has been bandying about the thought of adding or allowing insurance companies to start doing rating on the basis of weight. But if you followed this at all, you'll know that there's a big problem. One of the easiest indicators for obesity is BMI, your body mass index. It is also unreliable and possibly the poorest measure for obesity and weight. So as we move forward, we're likely to hear more a discussion about how we measure the measure of obesity and then how we charge for it. So here are the levels of plan. It's just important to note that it is a real calculus, and here is where health literacy becomes so important. You go to the marketplace and you make a decision. The benefits are the same. The benefit plan is the same regardless of what level you choose, but the question is, how much do you want to pay? Do you want to pay more in a premium or more in a copay? So it's inversely related. The lower the premium, the higher the copay. You will see on a bronze plan, it's 60% actuarial value. What does that mean? That means it takes the average plan, the average usage, and it says that insurance pays 60% of it, and you end up paying 40% of it, both in your premiums and your copays. It has the lowest premiums, the highest copays. On the other side of the equation is platinum, which is 90% actuarial value, which gives you the most coverage per se because you pay the highest premiums and the lowest copays. That is marked out because in the state of Missouri, our marketplace did not offer a platinum plan. But it is important to note that everyone, regardless of whether you purchase in the marketplace or you offer insurance at your place of business, every place must have at least a bronze plan. It is bronze plan or above to meet the individual mandate. Now, we looked at a survey that looked at employers across the United States, and most employers offer a gold or better plan, which is to say, when President Obama says you will be able to keep your insurance, that is essentially what he's saying. The spirit of it is that you will be able to keep the plan you have because statistically speaking, you already exceed the bronze plan. Now, here are two things I want to point out to you. If you purchase insurance on your own on the individual market, this same survey found out that most people on the individual market had plans that were worse than bronze. So when you heard all about these cancellations earlier this year, most of those had to do with the cancellation of plans that did not meet the Affordable Care Act. The troublesome part is, and we're following this, is think about it. If you were running a business and you were only required to offer a bronze plan, but you were offering a silver or a gold plan and your premiums went up by 20%, you needn't do anything but lower down to a bronze level or to increase the premiums and increase the copays, which is to say, as we move forward, people on the individual market are getting better insurance, and the people on the group market may actually see some of their benefits hollowed out. This is something we're following. This is something that, as Americans, we should all be concerned about. Here is the chart to look at. If you're interested, I can email you. You'll see on one side that most of the employers have good plans, and on the other side is the individual market. They had to create a special thing they called the tin category, and those for plans that did not qualify. Here is just a quick list of what benefits are included in all insurance plans. All insurance plans, it's important to note, need to have mental health and substance abuse or substance use services. That is part of something that happened not as a part of the Affordable Care Act, but it's called parity. Mental health and physical health have to have a parity of services. We have a big problem in Missouri. We do not have enough mental health capacity to meet all of the requirements, and this law actually compounds that because now people have insurance to cover that. It's also important to note that pediatric oral and vision. Most plans have accepted a pediatric oral, and our state is moving in the direction of improving, strengthening oral health. The pediatric vision, I do not believe is part of the plan in the marketplace. It's a long way around saying even some employers are asking for exemptions on pediatric oral and vision. So if you work at a place that does not cover that, don't be surprised. Your sector or your company may have gotten an exemption. Here is, I mentioned, if you cannot afford insurance, you will be able to get help in purchasing insurance. This is only in the marketplace. And this says that if you earn between 100 and 400% of poverty, that is between $23,000 and $94,000 for a family of four, you can get assistance from the federal government to purchase insurance. It's only through the marketplace, and it requires, and you'll see at the far end, it requires some contribution from you to purchase insurance. That is this quote-unquote skin in the game that we always talk about. Now, this is just a chart to make it clear without belaboring the point. So you go to the marketplace, you fill out the application, and it says, guess what? You qualify for 200% of poverty. That is, you must pay 6.3% of your income. You pay 6.3% of your income, and then the federal government makes up the difference of your percentage in the form of a check to the insurance company. So if you were a real optimist, you would say this is great. Lots of people are getting assistance to purchase insurance. If you were a pessimist, you would say this is really good for insurance companies, because insurance companies are getting subsidized to purchase or to provide insurance, sell insurance to people who otherwise couldn't afford it. Now, health insurance marketplace update, I just put this in to know that the interesting thing is when this law was passed, it said you could go to the marketplace and purchase insurance anytime you wanted it. But somewhere in the discussions with insurance companies said, guess what? We don't want to insure a lot of sick people. And we don't want a lot of people being diagnosed with a sickness and going to the marketplace and purchasing insurance. So what they said is they were going to follow the Medicare guidelines for enrollment. There's going to be an enrollment period before the beginning of the year when you can enroll in the marketplace. So if you did not get in the marketplace by April 15th, you cannot get in the marketplace right now by just walking up. However, if you have had one of the acceptable change in life circumstances, divorce, change of geography, change of change of state, those kind of things, you can purchase insurance through the marketplace. Additionally, if you are a company and you are hoping to go to the small business marketplace, there is continual open enrollment there. So there is limited enrollment for the individual market. There is continual open enrollment for the small business exchange. Now, the big question is, will plans become cheaper? And the answer is nobody knows. So here's the answer to how will the plans become cheaper. One of the things is that insurance companies were put under a lot of pressure to keep the cost of their plans down. And one of the ways they kept the cost of their plans down was omitting some of their most popular networks. Most notably, BJC was omitted from one of the insurance plans in the St. Louis market. Why did they do that? Well, one could say it was a kind of it was a move by the insurance company to keep their costs down. That may be true, and the insurance plans were affordable, but there's another thing going on here. The insurance company that we're talking about, Anthem, also set up a private network to sell their own plans. And believe it or not, BJC was included in their plans, which is to say that the insurance companies are playing a lot of games. Some insurance companies have decided not to enter the marketplace in some states, and maybe next year they will. Some insurance companies entered and were planning to fail, and then we're hoping to go to different states. If you followed how insurance companies have played with this, they are playing a kind of seek and find kind of strategy. What the marketplace looks like today is not what the marketplace will look like in 3 years. I would suspect to you that we will have more providers, we will have better competition, and we will have better opportunity for the kind of cost savings that the law intended to provide in 3 to 5 years than we do right now, because not all insurance companies are participating. They were waiting to see what happened in the election. They were waiting to see if these things failed. And the fact is because they are up and running in all 50 states and the District of Columbia, they probably are not going away, and they will only get better. And by getting better, I mean they will be better with health literacy, they will be better with outreach, they will be better with market share and/or carriers, and there will be better network understandings. Coventry got into our current marketplace and did not have the provider networks necessary to match what their insurance promised, and they are scrambling right now for networks. In coming years, this will not be the case. This is a test year. I would suspect it's not going away, and it has to get better. But this is all predicated on the final two bullet points there, participation and the cost of care. The fact is that these marketplaces need young people, 18 to 30-year-olds, to sign up. The fact is these marketplaces need healthy people to sign up regardless of their age. They need lots of people who aren't going to use care to pay for the people who are going to use care. And for this, once again, for this, I have to use a most cruel term, the near elderly, the 55 to 64 crowd. The fact is that they are on 3 to 4 pharmaceuticals. They're expensive, and they're going to cost more money. How many non-users does it take to offset the cost of the users? And that is the calculus that we're dealing with. Yes, ma'am.
Small business marketplace, if the employer themselves don't need the insurance because they're some sort of a group plan, can they still offer it to the employees?
Absolutely. Absolutely. So the question is, if the employer themselves doesn't need it, can they still offer to their employees? On the small business market, absolutely. And there's this really, one of the reasons why, and it's called the shop exchange, one of the reasons the shop exchange is not up and running is because they had some delay in creating this real functionality component to it. So currently, if you go to the shop exchange, the small business exchange, you just buy a plan and you offer to your employees, and they can choose to take it or they cannot take it. If they don't take it and they qualify for a subsidy, you can't be fined because you offered it. In coming years, and in the next couple years, what they're going to allow is a business to go there and create an account for each one of those employees and allow the employee to choose which carrier they want, what level of insurance they want. So let's say you go in and you say, I'm going to pay for the bronze plan only. As the individual, you could go there and say, I want to put in more of my money and I want to go to the silver plan or to the gold plan. That is the functionality that the small business exchange will offer in the coming years, does not offer at the moment. And it's only paper applications at the moment. So if you are fewer than 50 employees, You don't have to offer insurance. So we're not talking, if you were above 50 employees, you have to offer some form of insurance, and I can answer that question. But to your point, if you wanted to do that as an HSA or an HRA, you could do that because you're under no responsibility to offer insurance. The interesting thing is this, is that many employers are going to look into this calculus as a way of bringing down the cost of insurance. Now, I can only use the Missouri Foundation for Health. I'm sure operations would love that I was telling you all about our insurance. But we went to a higher premium, a higher deductible. But we got an HRA, and as a way of bringing down the cost of the insurance, they put in the cost of our deductible into the HRA. Now, why am I telling you this? Well, the interesting thing is, every year, every insurance plan needs to meet the bronze minimum, okay? But the bronze minimum is based on an actuarial value of 60%, not on a cost or what it pays for. So every employer could decide to get a plan that is technically not acceptable under the Affordable Care Act. But if they pair it with a savings account, they could bring the actuarial value such that it went to the 60%. So we saw this in Massachusetts. Massachusetts actually saw a huge amount of creativity in their small business market, because before they said we have to have 85% participation, these are the only prices, these are the only plans we can offer you. But now insurance companies are saying, listen, we've gotten rid of many of the people the brokers who sell for us aren't selling in the same way because people are buying through the marketplace. But why don't you go out and really look at small businesses and try to come up with custom plans that will be acceptable and will meet the needs, because every individual has to have a bronze plan minimum. Yes, sir.
You mentioned about the cost, and I sell some health insurance and do more financial planning, but in the situations that I had coming up this year, most people have cost. And I don't do on exchange, I didn't get certified for it. But anyway, but most of the clients I take care of are either early retirees or self-employed. And some of those people renew their coverage from December to go to this December, but every offer on the exchange, off exchange, their premium is higher and their out-of-pocket is more than what they're paying now. They're going to get raised, okay? And then the other comment you made that kind of question is on the BJC. Again, offer an off exchange, had a client, went into the Anthem off exchange, but BJC is not covered. Now it's covered in the plans that we used to sell, but those plans are not available anymore. So I'm trying to figure out where your disparity is there, because we can't sell a plan with Anthem that has the warranty. So like I said, every case, the one I have premiums actually higher are going to be higher than later.
So the interesting thing, the latter question, the former, the higher of the premiums paying more. I mean, again, these are tough particular questions to answer, because we're looking generally what happens, and that's why there are some people who are paying more. There are some people who are going to pay more. For the vast majority of people, they're paying less with similar or better benefits.
Man, I have a friend that does it full time, and he goes on the exchange, and it's gone a lot of places where people got subsidy. Those people are paying less only because of the subsidy. I've yet to see a case that they're actually going to pay less than what they were paying before for similar coverage. Understand, I don't do a tremendous amount, okay? But,
And you are correct. The subsidy really changes the equation, doesn't it? So, and when I say that people will be paying less, absolutely, I'm taking the population that is getting the subsidy or taking advantage of the subsidy. As for the latter question about BJC and their offering, the fact is that Anthem would like everyone to go to their private exchange or to go to the marketplace. But you can't, and you can't. So this is a part of a change in a business model. This, to be truthful, this is a testing to see if their private exchange even works. if it does not get the kind of critical mass to make it worth their time and money, we might see you being able to sell through their private exchange as a way of reaching out and keeping it viable. Again, this goes to the kind of testing we're having with insurance companies. Things are going to look very different 3 years from now. Was there another question over here? Yes?
When we consider the risk pooling and population increase of those individuals coming on to the healthcare platform, and we see that as those numbers grow, theory that the first person that's insured, is, whether they're healthy or whether they're 60, would pay a larger premium than the 347,000 person. But as that grows, is there any probability that we'll see premiums actually reduce as a risk pool increases?
So for every study that says yes, I can show you one that says no. And if you talk to insurers, they'll say, or you talk to insurance brokers, and they'll say, no way, this doesn't work. But the Congressional Budget Office suggests that, and it's not quite a term of art, but bending the cost curve. We are going to see some bending of the cost curve. So if you think of health costs, and again, not insurance costs, so this is where there's a little bit of a word game that takes place. Will health insurance costs change in America? We don't know. We suspect they will, because hospitals will get more efficient at providing care because they're being forced as a part of this law to improve quality over quantity. They won't be paid for medical errors, etc. So if you improve the quality side of it, you're going to bring down the cost, and as you bring down the cost, because insurance plans are required on that that medical loss ratio to bring it down. But let's think of it this way. Medical costs in America are going up almost as a straight line, and the goal is to bring it to a 1 to 2% or arrest that line. So when we talk about bending the cost curve, we really talk about getting to 0 or 0.3%, those kind of increases, not double-digit increases. The thought of bringing it into a negative or bringing the actual cost of care or insurance down, I have not heard a single person talk in those kind of terms, other than the groups that are for universal health care, single payer. People who talk about single payer, a Medicare for all, suggest that we could bring down the cost of health care, we could bring down the cost of health insurance, because we would all be paying a capitated rate based on what we earn. So along those lines, but the question is still a big question mark. Yes, sir?
What will be the effect on health care and its costs if 20 million undocumented immigrants, and then later there are 30 million families that would be allowed to enter this country in the chain that's allowed? What would be the effect of this group when they have an average educational level in about 3rd to 4th grade and their incomes are low?
So the effect that they'll have on the system is no different than the effect that they're currently having on the system, because they have been left out of this health care law altogether. So
It will be legalized eventually.
Oh, I'm not touching the legalization question. I'm talking about ER utilization. So the laws that determine whether you can show up at the emergency room or not did not change. So here's the thing. I want to talk about emergency room usage and what it costs us. So when you show up at the emergency room and you don't have insurance, you're going to go into medical debt. But you're also only going to have your symptoms treated. The laws that allow someone to show up uninsured and be treated, they're called the EMTALA laws, they say that only the symptoms need to be arrested and then discharge is possible. So if you are undocumented or you are uninsured, you can still show up at the emergency room, you will have your symptoms treated, and then you will go home. And we know from patterns of usage, you will then probably show up again to have those symptoms arrested, and that pattern of behavior continues. It's very high cost. It doesn't have very good outcomes. But I want you to think about something that is more concerning to me and should be concerning to every person in this room. We are we have a generation upon generation of people who do not know how to use our healthcare system. And if you see your parents going to the emergency room, you begin to see the emergency room as your primary care outlet. So the problem with the undocumented population not being allowed to purchase insurance, not being covered by this law, the individual mandate, is that the emergency rooms will still be their primary outlet for care, and their children, who presumably will be naturalized and or are currently American citizens, will be becoming a part of that generation who doesn't know how to go to the doctor. And it's the not knowing how to go to the doctor that is going to cost us in the future for all American citizens, not just the undocumented population.
That doesn't really address, once they become documented and their needs are now legal.
Once they become documented and they are naturalized and or citizens, they are bound by the individual mandate and will have to purchase insurance.
Thank you.
So I see that I'm almost out of time. So I wanted to point out a couple things. One, the state of Missouri did not expand the Medicaid population. By not expanding the Medicaid population, you will see right here, Missouri has one of the most restrictive Medicaid programs in the United States. You'll see at the far end, for children up to 300% of poverty, they are eligible for the Medicaid program. But if you are a parent, you are only eligible up to 19% of the population. That 19% of federal poverty, which roughly translate to about $3,000 annually. If you earn more than $3,000 annually, you cannot get Medicaid. If you, and you see on the far end, if you are a childless adult in the state of Missouri, you cannot get health insurance through the Medicaid program. The fact is that 80% of the uninsured in Missouri, and there are about 825,000, 80% of them either have a full-time position themselves or live in a household with a full-time worker. These are the working poor, and they are not going to be helped at all by the Affordable Care Act, because bad news is you do not qualify for the subsidy. Bad news is you do not qualify for an expanded Medicaid program. Good news is you're not bound by the individual mandate. So, I mean, I guess you got to take the good and the bad where it comes. But Missouri has decided not to do this. This legislative session does not seem like it will pass a Medicaid expansion program. You may be saying to yourself, why does this matter to me? One, every person in this room will sees their premiums go up when people show up for care without insurance. Two, the fact is that our health carriers and our hospitals in rural areas, especially rural areas, are going to be adversely hit by this, because at the same time that the Medicaid population was supposed to grow by the expansion, this federal government is cutting the federal funds that they give to hospitals to see the uninsured. So we may see a crisis. And the third thing is, and it has nothing to do with expanding the Medicaid population, but there are not enough primary care physicians in the United States to see all of the people who have insurance. If you think that as of next year, the number of insured has grown and will grow, the Obama administration says about 10 million. The fact is that there aren't 10 million, there aren't enough physicians to see this number. There is an answer. It's nurse practitioners. That's a whole, I was booed out of this room 2 years ago when I said it to a bunch of physicians. I don't want to be booed today, but nurse practitioners may be an answer, and I can talk about that later. Since I am out of time, I want to do two things. First of all, I wanted to put this up because we have partners in this right here from MU that have done lots of presentations, can do presentations better than me, I suggest. And they are talking about this issue. So if you have a question about it, please feel free to contact them. But I would say this, is the bottom line is that we appreciate those efforts and will provide support in the coming year as well through a collaboration with Health Literacy Missouri. The frontier of health care is health literacy. It's people knowing what to buy, it's people knowing what to ask, and it's people knowing how to understand. And when I say people, I include physicians and nurses in this. This isn't just a case of knowing what to ask your physician, it's your physician and or nurse practitioner knowing how to treat you, or in parlance, cultural competency. The Missouri Foundation for Health has committed to spending money, and we're working with MU, and we're working with other partners around the state to improve the level of health literacy with regard to purchasing insurance, with regard to understanding what it means to purchase insurance. Those of you who have purchased insurance on your own or work at a place that offers insurance know it can be a mind-bending proposition. And we need to help people be able to make those choices. Just sending people to the exchange and say, go choose your insurance product. Think about actuarial values, carriers, networks, in-network, out-of-network. These are very confusing things for most of us to do, which loops me right back to what happens when fewer and fewer Americans are in the middle class. How do we go and purchase insurance and understand what we are getting? Interesting. To this, not exactly to your question, sir, but you know that this law does not change in-network and out-of-network. Most of the plans you buy have an in-network cost, but if you go out-of-network, those costs are not controlled. So the thought that you might go to someplace and not have health care is not a fear. You can go to another state, you can go to another place, but the thought that those costs or those co-pays can go up is a reality that everyone has to know. And these are the kind of things that you have to know on your own if you are purchasing insurance at the marketplace. Final slide. This is my contact information. Thomas McAuliffe. I'm at 314-345-5574. If you have a question, you have a concern, you want to tell me I was wrong, I was right, I can dance, I was funny. If you have a group that you would like spoken with, please feel free to contact me, and I'll try to do the best we can. The Missouri Foundation for Health is unique in the United States. Not every state has a Missouri Foundation for Health. It is a resource at your disposal. We will answer policy questions, we will pursue research, and we will try to give you unbiased information at every opportunity. Thank you very much.